on the memory of an observer. And what is the information? It's a hard to define concept. Suppose we have a device that can produce 3 symbols, A, B, C. As we wait for the next symbol, we are uncertain as to which symbol it will produce. Once a symbol appears and we see it, our uncertainty decreases, and we remark that we have received some information. That is information, is a decrease in uncertainty of an observer. And the memory is the... And we are going to talk more about that. We have 3 major types of memories when we talk about psychiatry. We have the genetic memory, that is the information from the parents stored in the DNA, and most of the people perhaps are familiar with that. We have the external memory, which is the storage of the information from the outside environment within the neuronal circuits that change accordingly. And this is an important step in the development of this knowledge. Was done by Dr. Kandel, who is a psychiatrist at Columbia, who received the Nobel Prize for Medicine in 2000 for his work on aplysia. What is aplysia? Is a sea snail, which is an animal that has a very simple neuronal circuit. And what he's done was that he stimulated the animal with a small hammer on an extremity, let's say, and he observed that physically the connections between the neurons grow once the animal is exposed to a higher stimulation. And once the animal gets used with the stimulus, the process of habituation takes place, in which the connections between the neurons that once pruned and grew, they decrease both in size and in number. So there are many, many other evidences that the external information that comes to an organism is actually represented physically inside the brain, and we can talk more about this at a later moment. The internal memory is the storage of information generated in the internal fantasy life of a person, and there's an unknown storage mechanism for that, presumed to be somewhat similar with the mechanism of the external memory storage, but there's really not too much work done in this area at this time. One thing that I would like to point here is that one does not represent in the memory objects from the environment as they are, but rather as they are perceived. So what becomes fundamental is the relation between the individual and object rather than the object itself. You can think about any kind of example. Think about looking at the sky and seeing a star. No one is going to represent it in the memory as huge and big as it really is with all its physical properties, but rather like a spot of light on the dark sky in the night, which is very relative. That's actually not the star, it's the perception of the individual. And more than that, if you are walking when you're a child with your mother and you look at the sky and see those stars, and you have a pleasant moment there being with your mother, that will end up being memorized in an envelope of the memory where good affects are collected together. While if you are a child and you run from, let's say, some dogs, and you look at the sky and you see the star, that will be memorized in an envelope of the memory where terrible affects are clustered together. And what ends up happening is that later on in time during your life, there's a likelihood that each time you will see the same object, there will be more or less a similar kind of affect arise in one's experience. So the relation between the individual and the object is more important than the object itself. So we have 3 levels of representation or organization in the brain of the information. We have the genetic information level, which generates the initial brain structure. We have the external information level, which generates the external memory structure, and we have this fantasy information level, which actually generates the internal memory structure. And we are going to talk about each of them. So each level of organization depends on those below it. At higher level, one discovers properties that cannot be accounted for by the properties of any of the subcomponents. Everyone asks these days, where in the brain is love or altruism or any other positive feelings represented? Perhaps they are not. Perhaps they are at a higher level of organization of information in the brain. However, the emergent properties at higher level of organizations have the power to cause a change in the levels below within certain limits. And this is where all the therapies come into place, and we can talk more about them. In today's scientific medicine, we are beyond the dualistic era in which everything was split between being material or non-material. Scientists know pretty much today that the brain represents within its structure all the information that circulates through it. In one way or another, there is a certain imprint on the brain structure at the microscopic level of the information that comes and goes to and from that brain. What gives the information non-materiality is its property to jump from one medium of transport to another, therefore from one observer to another, both in space and in time. And this is where the old concepts of mind versus body, or mind versus brain, come into place. Today people think that brain is the brain and the mind is the function of the brain. But what's interesting about the mind is that the mind can be shared with others, and you perhaps would never be able to share, of course, the brain structure. So talking about the meanings, the genetic memory generates the first meanings for any given person. It is the blueprint of life, and the basic needs like hunger, thirst, sexual drive, and so on are generated by the genetic memories. And more or less, without satisfying these original meanings or needs, that individual would have a very hard time in the environment. The external memory generates meanings associated with the outside space via re-experiencing of a similar part of the environment as the stored one. So always the idea of meaning has sense when there is a comparison with what comes out as new from the environment and what is already stored, and it has to be at some point some kind of connection or identification between what's known already and what comes from outside. Otherwise, it won't make sense, and the individual is looking at something that does not resonate with anything. There's no clear understanding of what's happening. And then the general memory generates meanings stemming from the structural representation of the persistent fantasies. I want to give an example here. We see some of the psychiatrists, a lot of pedophiles that work with that are either in jail or in some kind of clinics specialized in this direction. And they have this persistent fantasy that the child that they abuse sexually is actually enjoying and having a pleasure in that act. And after years of treatment, actually, this persistent fantasy does not go away. It's very fixed and persistent in that person's memory. So one thing to point out here is that most of the people think that fantasy is something that comes and goes and it doesn't stay inside. It's actually perhaps a little bit different. There are many fantasies that are persistent, and they are represented internally as memories. And another example here, also from the child abuse theory, is when you interview someone in the adulthood and talk about the abuse that happened in the childhood, it turns out that it's very difficult to actually distinguish between what actually really happened, what's the external information, and what was actually part of the child's fantasy. And it's a very hard work to disentangle these two pieces of information. Perhaps they are represented inside more or less similar. And there are many studies done in this area that we can talk about. Now, this is a very challenging thing that I want to mostly talk with you and listen from you later on, questions or comments or challenges on this. Mental health definition. What is mental health? We don't know clinically speaking. It is speculated to be an integration in one's culture with well-functioning in family, social, and professional area. It is behaviorally oriented. As long as the behavior stays acceptable, the internal mental life becomes of secondary clinical importance, which doesn't mean it's not really important, but clinic-wise, if someone comes in therapy and talks about the wildest possible dream, the most aggressive, the most damaging and destroying, you won't call that person necessarily mentally ill. Actually, that's part of normal life, and this is why all the people go to all these violent movies and play these violent computer games. And it's actually thought today that in child psychiatry that it's actually important to let children to play with guns and to play some kind of violent-like games, because this way they end up acting these fantasies in play rather than suppressing them and then later on perhaps acting them in reality. Now, I don't share 100% this point of view, but I mostly wanted to discuss it with you and to give you some food for thought in this direction. What is the mental disease? The mental disease is thought to be a major malfunction in the brain machine, which leads to complaints to the psychiatrist by the patient or by others about the patient. And I'm going to talk about this word. The most important word here perhaps is this complaints. And I'm going to talk about it. Why is that important? So mental disease, it is manifested in behavior again, which is defined as the signal information from the patient to others, as well as the patient's physical interaction with self and others. But it's hard to pick it up when it's only manifested in the internal life. If it's a behavioral component there that bothers someone, either self or others, then it's much easier to pick it up as clinicians. So here is a very interesting paradox. If there is no complaint, there is no known mental illness, therefore there is an assumed mental health. There are, according to some epidemiological studies, about 15 million people in the United States only who have a mental illness that is untreated because it's undiscovered. And you don't have any legal right to go to someone and say, you know, I think you have a mental illness, therefore you should come to the treatment. It's very hard to pick it up if there is no complaint. If you do a screening for colon cancer, let's say, you might see a tumor, and therefore it's obvious for everyone that there is an illness there. But there's really almost no kind of screening for the mental illness per se, except very few exceptions like mental illness induced by a substance use or mental illness due to a general medical condition. So this is kind of similar with the question, when a tree is falling, is there a sound if nobody hears it? Given that the sound is the mental representation of a variation of air pressure on the tympanum, the logic leads us to believe that there is no sound when there is no observer, which obviously one can say it's not true, but it just points out how difficult it is to work with the relativity in terms of the mental illness diagnosis. The immediate cause of the mental illness is considered today to be a change in the structural composite of the brain, leading to an impossibility to process information according to the existing memory networks. And there are many examples that perhaps most of you might be familiar with. For instance, the decrease in the available serotonin between neurons, which leads to an exhaustion of vital chemical flow ingredients in depression, for instance, or increasing the dopamine, which is another neurotransmitter, which generates a superstimulation that encapsulates information between neurons without the ability to recycle it when it becomes redundant, generating persistent hallucinations and delusions in illnesses like schizophrenia and other forms of psychosis. That's the immediate cause of mental illness, right? Then we have the remote cause of mental illness, which perhaps is an imperfect interaction of the genetic information with the stored external information and with the stored internal information. And it leads to a traffic jam in the information flow, followed by a jam in the representation of this information at the protein physical level in the brain. And you can talk here about any of the illnesses. For instance, in a conversion reaction, the one common fantasy, which is the internal stored information, is of being taken care of. And the information from outside, the external information, is that you are actually not taken care of. And therefore, there is an enormous anger or frustration between these two levels of information that would generate such a tremendous painful reaction from the body that the body actually cannot handle that and finds an additional way or an alternative way to handle this frustration, which is, let's say, the pseudo-paralysis that people see in conversion reactions in which, let's say, a limb is not being able to be moved, and after the physical exam and the physical investigations, everything seems to be fine. It's what is called mostly psychological, but it's a way of actually getting that person to be taken care of, because now that person is sick, and the frustration went away between the two levels of information, and for the moment, at least, the discrepancy there is taken care of. Similar with schizophrenia, with anxiety, you have a genetic vulnerability. We know that schizophrenia and various forms of anxiety run in families. You also need to have, most of the time, an external trigger or stressor, which is hard to pick up in many clinical situations, but most of the time things really don't happen out of the blue. There must be something happening there. And then the internal information becomes tremendously important in illnesses like schizophrenia or anxiety. Think about an anxiety person who, let's say, has a panic disorder and goes on the street, has the genetic vulnerability toward the panic disorder, finds a situation that is very dangerous, let's say with a 10% risk of having an accident. That's the external information. Then you have in the internal information an increase of that risk to perhaps 100% when this person is already fantasizing about actually dying in the next 5 minutes. So it's not really only what's happening between the nature and the nurture, which is the genetic part of it, and the external information, but also very important what is actually fantasized about in one's mind. And the same with schizophrenia, with all these fixed false fantasies or beliefs, like various delusions from paranoid to grandiose and so on. So talking about the meaning of the mental illness. The meaning of the mental illness is in general relative, depending on the memory parts that the illness interacts with. So let's say someone is a spiritual person. One could think, well, I'm ill because that's what God wants, and therefore I have to take care of this or handle it. Or someone might say, I am ill because someone else from outside sent some kind of virus in me, and they want me to be ill and so forth. So the meaning itself is a relative for various persons. It might be different for each of the patients you might mean. However, meanings have a pyramidal structure in general in a group of people, with the common meanings represented almost identically in the group, while the specific meanings themselves are particular to an individual. And a very important point here is that in mental illness, new meanings are assigned to old memories. This is a very important point here that I want to discuss with you. Let's say there is a therapist from the same culture with the patient, and they both get together and they start talking, and the patient talks about a concept in that culture that is assumed by both as being known. Let's say in my culture or religion, they talk about Jesus at some point. And the therapist might say, well, this sounds like a very spiritual person, and I appreciate that. Sounds like a strength of that person, and so on, because everyone has this common understanding that Jesus or another figure from another culture has a certain meaning for most of the people. However, you find out in the clinical interview that actually for that particular patient, he thinks that either he is Jesus or that he met Jesus 5 minutes ago and Jesus told him to actually come here and tell the psychiatrist about whatever, the fact that he wants to harm his children or some other horrible things that one could actually link with an old memory that most of people would assume is actually completely different from the perspective of the meaning with which what actually the patient himself or herself assigns to that. So as you can see, the meaning and the cause are not contradictory concepts. Cause is the pathological interaction between the information components that generates then a structural abnormalities. And we talked about various traumas, genetic malstructures, fixed persistent fantasies, and then the meaning is the effect of this pathological interaction on the remaining or more so-called normal areas of the memory. there is a vicious circle of meanings in mental illness that perhaps you know, or you need to know when you work in a therapy format. A paranoid person creates trouble around, and people start interacting with this person in a certain way because they're very concerned with the patient. The patient becomes more paranoid because actually people are coming after him, but they are coming for a good purpose, which is sometimes hard for the patient to pick up. A borderline patient generates rejection around because of a certain impulsive behavior and inability to handle relations with others. And by creating this rejection, the pain that the borderline person experiences increases a lot, and more or less the person becomes more borderline because the environment reinforces actually this rejection that the person perhaps experienced sometime earlier in the childhood. With the performance anxiety, you might have a bad performance when you have to do a presentation or whatever, and then you learn that, hey, I really cannot do it, and performance anxiety increases later on. With substance abuse, there's a lot of failure going on, or relapse, and people end up moving from substance abuse to a higher level of pathology, which is substance dependence, where their entire life might very well get messed up because of this particular illness. And where the treatment comes into place is based on the relation between the therapist in general, not necessarily the psychiatrist, and the patient. And there's a balance in this relation in which the patient comes into the relation enmeshed in his or her own transference, while the psychiatrist or the therapist also brings into this relation what is known as being the countertransference. Now, what are these two concepts? When you think about the transference, it's actually the meaning that the patient assigns to the relation patient-therapist based on what this patient was exposed to in the past and what he or she knows that happened to him. And a lot of feelings from the past are projected inside this relation. And the psychiatrist or the therapist himself or herself also have memory in the past, and it's almost impossible to conceive. Perhaps it's impossible to conceive about not having a countertransference or a reaction or a meaning interpretation of a particular relation with a particular patient at some point. Now, what are the components of a patient-psychiatrist relationship which stays at the base of any kind of therapy? Well, there are a number of them, and we're going to talk a little bit about each. The clinical, the financial, the boundary confinement, and the fantasy part of the relation. The clinical part is the most simple one, and it has to do with the therapeutic contract in which both of them know that they are there to target a decrease in some symptoms that the patient came in. The therapeutic contract can be implicit in some forms of therapy or explicit, discussed about, and even the patient might sign a contract like in some forms of cognitive behavioral therapy. The financial relation has to do with the financial contract. Money are transferred to the provider in exchange of the work value. Up to here is kind of simple and easy to understand. But there is a very important meaning of the financial relation in the therapy format. It's more or less an anchor in the external reality, one anchor for the patient. So what's happening in the therapy is actually that the patient and the psychiatrist or the therapist travel together inside the fantasy life of the patient. However, you can't travel that far, and the fact that the patient has to pay certain amount of money offers this patient an anchor in reality. And what's important here is not how much money that patient pays, but it's important to know that each time you change the fee, either you decrease it or you increase it, there is a meaning that this patient starts to fantasize about and to think about why did this therapist do this. Maybe because he or she likes me, maybe because wants to make my life a little better. In any kind of direction, you start creating meanings by changing the financial dimension of the relation. And I'm not saying you shouldn't do it, but when you do it, you should be aware that there is a meaning that you bring in the relation. And then this is the boundary confinement of the relation. This is a very important concept. It offers structure to the patient-psychiatrist or patient-therapist relation. It is preset and defines the therapeutic field. And here you include the time frame of the therapy. If you have a 50-minute session, it's a 50-minute session, and no less, no more. Then you include here the space where the therapy takes place, which hopefully is done in an office and not in a restaurant or in a car, except in some form of behavioral therapies when you might need to go there. Here you include the way the therapist is dressing, the type of subjects that are discussed about, the fact that you don't want to do any kind of transactions with the patient, but strictly based on the therapy context. And why is this important? Because actually it isolates the patient from the outside reality as much as possible, leaving space to the inside reality of the patient to come out and be discussed in the therapy. And it's very important also because it creates an artificial discrepancy between what patient wants to do and what patient actually ends up doing, which makes it easy to point out meaning that transgress actually the boundaries into the unconscious. And what do I mean by this? Let's say a patient has to come to the therapy and goes to the subway and takes the subway in the opposite direction than to your office. Well, the patient comes next session and you might start talking about this, let's say. Now, why did that happen? Well, perhaps there was a determinant there. And what's that determinant? Well, most likely it's the unconscious part of the patient which didn't let actually the patient to come and talk about painful issues in his or her life. It is too painful to bring out and look at inside the therapy relation to the problems that actually this patient handles in life. And therefore the unconscious made a determination to take the subway in the opposite direction, which is not, let's say, always the truth, but there is an opportunity there to discuss with the patient the discrepancies between what one wants to do in life and what actually one ends up doing in life. Because why do people come to therapy? Well, most of the time they come saying, you know, I want to be like this, like this, like this, but I can't. Here's what's actually happening in reality. And there is somewhere a major discrepancy that can be pointed out inside this boundary confinement. Then the fantasy component of the relation patient-therapist is very important. Two isolated fantasy worlds meet via channels of transference and countertransference, and new meanings are given to past relation memories inside the new relation. An important point here is there is no meaningless observation of the patient from the therapist or the psychiatrist. It's an extrapolation from a physics principle that perhaps many of you know, the Heisenberg principle. It was a time in the 50s when psychoanalysts used to dress all in black suits or with black ties and kind of look the same in an attempt to be as neutral as possible and to not introduce artifact or additional meanings inside the therapy relation, but rather let the patient come up with his or her own story of life, not influenced that much by the therapist. In time, it was observed that actually this is not possible. And each time when someone interacts with the patient, if the therapist is a young woman, makes a difference with the context in which the therapist is an old man or the other way around. And there is always a meaning that comes into the relation. And what's the Heisenberg principle? Probably some of you know. It's about observing an electronic particle, let's say, with an electronic microscope. And the reason why you can do that is because each time you want to observe an electron, you send actually an electronic beam to observe that electron, but the electronic beam is formed also from electrons, and the electrons interact with each other, so each time you try to observe, you actually change either the position or the speed of that electron, because you observe one object with the same type of objects going toward that electron. Here is the fact that you observe a human being with a human being, or it's observed by another human being, and there's no way to not create additional meanings inside that patient-psychiatrist relation. Now, the scientific approach, in an attempt to actually reduce as much as possible this relativity of a relation patient-therapist, tries to employ objective observation as much as possible, and does this through using valid, reliable, sensitive, and specific methods as much as possible. What is validity? Validity is an attempt to use measures that actually measure what you really want to measure and not something else. For instance, there was a time when the cortisol level, the hormonal level of the cortisol in the body was used to be thought as being equivalent to with the level of depression. So people used to measure the cortisol level, and depending on what that level is, you would be able to say how depressed a person is or not. And in time, it was observed that actually the correlation is not so good. So that type of measurement is not really a very valid type of measurement. Then the reliability is actually use of a measurement in which each time you measure the same thing, you should obtain the same results if you start from the same parameters, and not variable results in time by using an unreliable method. And an example here is if you would, let's say, have someone on Tegretol for manic depression, and you measure the level of the Tegretol, and you want to think how compliant is this patient with the Tegretol, and you see that the level of Tegretol decreases actually in time, and you might think, hey, maybe this person is not compliant and I should talk about this with the patient, while in reality we know now that the Tegretol is auto-inducing its own metabolism in the liver, so the level of the Tegretol in the blood goes down, not because the patient did not actually take the medication, but rather because there's this auto-induction which makes the metabolism faster and faster. And I can give you some other example about the other types of characteristics of an objective observation. We don't want really to spend too much time now. I just want to point that there's an effort to quantify results in psychiatry, and you will see a lot of psychiatric studies done with a lot of numbers and methods and data analysis technology employed. The reason why this is done is for population significance, and mostly because the funding comes actually from various sources, either private, non-private, governmental or not, and they want to know what's the significance for the population. However, the meaning of these findings for one particular patient might be very limited or almost equal to zero, and you should always be very careful with this. So when you say, you know, what I'm going to do with this patient? Well, perhaps most likely I will be successful if I use this type of method. Well, that's true, but that's true for a certain population, and you don't know if that person is close to the mean of that population or is somewhere in the extremities, and therefore what's known in the literature for population might not really apply to your particular patient. This is why it's very important as a clinician in general to spend good amount of time with the patients, to take a good history and have a good understanding of what's actually happened with that particular person. One example of this scientific approach, what is known as the rat race. Two groups of rats were put by scientists to swim in an opaque water. And one group came to a hidden island on which they could rest. The island was below the level of the water, so they couldn't see it, but they came to it and they could rest there. And the other group didn't find any island in their own recipient. After 24 hours, they repeated this experiment, and there was no island for both groups. And it turned out that the first group of rats swam more than double time than the second group. And what's interesting about this is that actually the memory of the island kept the first group of rats active longer than the other group. And there was a real island. However, it is speculated today that perhaps um, an accepted island that you really didn't experience but you believe in can induce the same kind of increase in performance. And this is a very simple example with a group of animals. It is speculated that perhaps is more or less similar in humans. And there's a network of such islands which are represented structurally in the memory with some proteins there, and they are technically called nodes in the memory network. And there are genetically pre-programmed nodes, there are external reality-induced nodes, and patient-created nodes. Fantasies of the patient, real islands, and some mandatory things like eating or drinking, without which one could not survive. Now, who makes the choice which island to go for? Well, we like to think that not the therapist. Patient needs to know the nodes of the network before making an informed decision. So one major issue that comes out in therapy many times is who takes the control, or who drives the car, or who is at the wheel. And we like to think that actually we give the patient this choice. And I want to point out that here might be a discrepancy between how clinicians see this process of making an informed choice versus how, let's say, someone from the clergy would see it. And I think actually there is a boundary between where the clinician's field ends and where the, let's say, the clergy field might actually start gaining more importance. And what do I want to say by this? If we remember about the definition of the mental illness, it has to do a lot with what is expressed outside, while what's happening inside, no matter how violent it is, as long as it's not expressed outside, clinically speaking, it's fine. All the people experience that. And that's the step or the boundary from which, let's say, a spiritual context might provide that particular person with a more upgraded or improved or an increase in the mental hygiene, but that's not clinical work. And psychiatrists, as well as perhaps all the therapists, should know when is the point from where the patient should actually be referred to someone else more specialized or trained or with knowledge in a spiritual field rather than the clinical field. So one last comment today would be that these islands are either reinforced positively or negatively by the external environment. So they grow or they decrease in sizes and in numbers, depending on what kind of feedback from the environment this individual gets. And this is actually, I can recommend you a book. It's called The Mind Within the Net, and it was written by Manfred Spitzer. He's a professor of psychiatry in Ulm in Germany, if I remember correctly. It's a wonderful book which talks about these memory networks that are actually dynamic, and they don't really remain the same, but some of the networks grow if they're reinforced positively, and some of them decrease in size and number if they are reinforced negatively. So what you want to do with the patient is to end up, rather than letting these networks to grow or to change without control, to actually take control of what's happening there and help the patient make a choice, and before actually making a choice, being aware that there is actually a choice. Because most of these people that we see, let's say borderline people, they have this behavior that they have extremely impulsive and damaging to self or to others, not because they make that choice, because for them there is no choice in that moment. That's the only thing that they could think about or conceive. And the therapist hopefully helps the patient in the relation to actually once be aware that there are choices and then being able to make an alternative choice. And the choices are made as long as there are no major limitations, but at some point in someone's life you start having limitations, like limitations by age, limitations by immunity status in someone immunocompromised, like with HIV positive, limitations by terminal illness, limitations by so many other things that happen toward the end of one's life. That's the time when on the mental screen of a person, one is one step closer to seeing the words game over. Thank you. Sure.
I just wondered if you could comment on how the model you presented relates to the division between emotional experiential memory and semantic organization.
It's actually a very interesting point I was thinking this morning. What we know today is that there is a clustering of memories based on emotional components. So whatever is a good memory experience during the life goes in one kind of envelope in the brain, and whatever is a different type of emotion goes in a different part of the brain. And this takes preponderance, or is even more important than the semantic part of it. The semantic one is somewhat less important than the emotions. Now, what is emotion? Is a hard to define concept. Again, it's perhaps correlated with the effect that this information has on some basic centers in the brain, where there are some discharges of various neurohormones and hormones in general that actually induce a certain reaction which is experienced by the body as being pleasurable or not. And if it's pleasurable, you might go for it, and if it's not, you might really not. But the emotions actually take preponderance in the way of how the brain information is organized as opposed to the semantic one. That's what we think today. Is there other questions? Sure.
Psychotherapy in general has this difficult problem that they can find that untrained people, that is people who have no idea about psychopathology, brain chemistry, that have no therapeutic skills in the ordinary sense, still, however, bring about help in other folks.
Correct.
And, of course, the opposite is equally true, that is highly sophisticated psychotherapists seem to be unable to help individuals and otherwise. So how do we handle that kind of a difficulty in psychotherapy?
Well, I think, and this is my personal opinion, perhaps the most important step that one does in a therapy environment is to correctly diagnose a person and to direct that person toward the proper provider. Because there are many, many times situations in which actually someone is not having a diagnosis where a type of treatment is mostly indicated for. However, that person ends up in that type of treatment because that's really what was available. And they might have some results, but not the best. And I can give you examples in all the directions. Let's say dialectical behavioral therapy is a very kind of new therapy. I mean, it's been around only for 15, 20 years, and it's used mostly for borderline personality disorder people. And it has to do with gaining skills of being able to manage properly the emotions that they experience. They experience very intense emotions that actually change negatively their behavior, and they learn ways to manage this. Day treatment program in a hospital where you employ this dialectical behavioral therapy format. And there are a ton of people out there who need a day treatment program. There's no other day treatment program, so therefore they end up being referred there. So you end up talking to a group of people with schizophrenia that almost have no overt emotion. about skills to regulate those emotions. And what kind of results you obtain with that? Well, it's hard to say. Perhaps there's something. It's not really totally a waste of time, but perhaps there's another setting where you could theoretically send those people. So I think where the decision is made where to send this patient or person is a major step to diagnose correctly and to say, is this an illness or this is a family problem or a life situations or a spiritual crisis where this person shouldn't see a clinician, should see someone in that particular field. So that's my thought about that. Any other question? Okay.
Given that the focus of this conference tends to be on the existential aspect, do you see a significant divergence between the present-day psychiatry and the use of the relationship as a healing element?
That's a very interesting question and very deep, I would say. We would say like this: the relation is perhaps the most important. However, there are some modifiers of the person's behavior that are outside of that relation. And those modifiers are extremely deep. And you might very well end up to fail in approaching a treatment using only the power of the relation, because there are some other determinants back there which are so deep that they actually overcome the relation. And by that, you can think about anything. Again, from genetical limitation. One might not be able to process very well the relation. And you might think, hey, well, I'm doing everything for this person, but how is that person actually perceiving you might make a lot of difference there. And also in this brain limitations based on, let's say, running out of neurotransmitter. If someone has a depression, this person runs out basically of a liquid, of a neurotransmitter in the brain, right? And without that, if you look at the picture of the brain, you do a picture, it's called a PET scan, and the depressed person looks like the light looks right now. And when you turn it on properly and the person is treated, actually is a brightness there on the screen. So when the person is in this kind of darker phase, they won't be able even to process, to engulf inside, to interiorize what you deliver to them. This is why it's said, for instance, that spending 10 minutes with someone with schizophrenia might equal an hour with someone with a less intense disorder. So I'd say is the most important component. But our job as psychiatrists and probably many other therapists is to pick up the other limitations that actually don't let that particular patient to be engaged properly in a relation. Okay. Is there any other question? Sure. Mm-hmm. Mm-hmm. Right, right.
So how, and these days, I've heard that people are not doing this practice anymore because they find that it's at the medical school now, no one is doing the psychiatry. They're not being taught as well as the procedure and guys and look at something. And there's no meaning in it. And not like in the old days, we try to kill someone and see what meaning in helping psychiatry. Compassionate. Now, less and less compassion in psychiatry, more and more in medicine. So,
That's an excellent question, and actually I would say like this. It's the most common reaction that people might have towards psychiatrists these days. It comes from a couple of reasons, but let me say one thing. First of all, if you go to the medical school, and this is a tough topic, but if you go to the medical school, one thing that you learn there is to do autopsies. And when you do an autopsy, you work on a brain and you see it's there, all right? So there is a mechanical or material substrate of what's happening in one's mind. Then, if one's behavior is influenced, or one's emotional life, or one's spiritual life, all right, is influenced by some mechanical malfunction there, someone has to take a look at that. And psychiatrists indeed started by being kind of a therapist because they haven't had the knowledge, as no one had the knowledge of, looking at the brain, right? But when you start discovering and doing study after study and study after study and figuring out that, hey, actually there's something going on here, indeed people focused a lot on that. Now, let me give you one short example here. There was an experiment in which they took a mouse and they put that mouse in a small room, and there were some clues there that directed the mouse toward the food. So the mouse went and found the food. And then next day, they took the same mouse, and there was actually a group of mice. And half of that group was taken next day. They wrapped around the eyes so the mouse couldn't see, and they let the mouse again in that environment. And based on the clues that the mouse learned the day before, the mouse was able to find where the food is because he was able to touch and feel around how the environment is and where are the angles, and was able to go to the food. In the same day, the other half in that group, what they did was they wrapped around the eyes of the animal so the animal could not see, and they did one of those things that are done in animal laboratories, which is to extirpate or to take away a small part of the brain called hippocampus, right? Hippocampus is a small part of the deep inside part of the brain. And they figured out that actually the mouse was not able to recognize any of the clues in the environment and to go from one clue to another and to actually reach the food. And there was one step when people learned that actually the outside environment is physically represented inside in that hippocampus, which is vital for actually interacting properly. Now, along the same line, there are a ton of other examples that would show you that there are limitations in how one behaves in life because of these biological roots. And someone has to look at those. Now, if psychiatry is or not meaningless is hard to say. First of all, as clinicians, you look and you find, let's say, in the spiritual area, a ton of religions. Who are we, like any other clinicians, in the position to say, I'm going to reinforce this or that? Because saying spiritual means one thing, and actually looking at the differences of various spiritual tracks, you find an enormous amount of difference. So which one is the good one, which one is not the good one? All of them are good. I'm from New York. Even the people who've done what they've done in September 11, they've done that in the name of God or for some kind of spiritual reason. So as you can see, there is an enormous variation of actually meaning attributed to even the spiritual life. So what we end up doing is perhaps drawing a line, and the smarter thing to do would be to work on the person's equipment to engage in a meaningful life, and let then the person, or make sure there's a smooth transition for that person from the clinical work to whatever it is, spiritual work or other kind of mental hygiene that is done outside the clinical environment by people that are better trained, who can be anything from spiritual leaders or family or cultural leaders or so on and so forth. So if the clinicians know to draw this line and say, here is where our field ends, and this is where the other field starts, if we can make this link, rather than let the person go by himself or herself after they are well, if we can make this link, that I think that's a major gain. And well, there's going to be a talk at some point today or tomorrow by Dr. Puchalski about spirituality in medicine. And if you go and see that or listen to that talk, you will see that a major component is actually the spiritual assessment that one could do for a patient. And then if you identify that this person actually fits in a kind of spiritual culture that is not one of the most extreme and dangerous or violent ones, you might very well be able to link that person with someone, or to reinforce or encourage actually that person to go and pursue further in life what's meaningful for him and his significant others, without actually taking the role of either the spiritual leader or someone who actually chooses in life of that person what the islands of hope that person would have. But rather, at the most, you might want to make a suggestion, but it's actually the person's choice, which you might not share, but I'm willing to hear comments on that. Right. Well, I'll just answer shortly to that. You missed one important, the most important word when I say there's no complaint, there's no problem. It's actually there's no known clinical problem. The word is clinical. And as I said, there are 15 million about estimated people in the United States only with a mental illness out there, undiagnosed, untreated. But by epidemiological studies, it's estimated to be like that. You cannot go in someone's life and say, hey, listen, you have a problem, and I decide you have that, and then start treating them. It is, your hands are tied. It's a matter of legislation also coming into place, and that problem comes up, and you end up dealing with someone only when there is a complaint, because there's no way at this time to screen people and to find an objective test and to say, you know, we've done this, and therefore here is those who do have that mental illness. I'm not going to comment on that part. We don't care about the biological, because I think we should care as long as that influences the meaning of one's life. And of course, if it doesn't, that person perhaps shouldn't even see a clinician, should see someone in a different field. Sure. 15, if I remember correctly, 15. But again, by mental illness, I'm not thinking major mental illness like schizophrenia or so. In mental illness definition, you can include anything from dysthymia, or those kind of dysphoric moods that go on for years and years, and one cannot get rid of them and would like to. And they don't really impair the function that much, but it's really a kind of a miserable life that one lives, and perhaps there is a biological limitation for that, sir. Did you?
Well, as I'm listening to this conversation, it sounds like what I'm hearing with psychiatry, clinical psychology, I'm thinking of children, where so much of the issue is adjustment issues. Is what you're saying is, should there, like, it would seem that say the field of children is going to go more and more into the clinical psychology or counseling psychology field, and less over the child psychiatrists. I work in the school system, so I have to absolutely share with you how many people in the psychiatry is fundamental.
Right.
When that's not what you'd like to say, but everything else is private practice and cost. So much you
Right.
can't send them that. And so I'm just wondering, is the field changing that rapidly from what I'm hearing that psychiatrists becoming more and more into the medical and biological, or is it just happening through the training that you get?
Well, I'll tell you this. Actually, there's a reverse trend right now. The Accreditation Commission for Graduate Medical Education in the United States made it clear a couple of years ago that people should reinforce psychotherapy more than they've done in the last 10 years. And there's a reverse trend now, actually. There's more and more accent in psychotherapy. In my training, for instance, I have 3 psychotherapy supervisors and 1 psychopharm supervisor. And the caseload for psychopharm is bigger. But even though I see less psychotherapy people, because obviously it's more intense and more often, I have 3 supervisors as opposed to 1 for psychopharm. The other part of the question, if the field is changing or not, I would say like this. There's more and more evidence in this direction of the biological roots and limitations upon one's behavior and life in general when people become sick. There's almost no other group of people except MDs who are allowed actually to do those kind of biological experiments, can administration of various medication and so forth, to explore that area. It would be not being able to conceive the fact that you have signals that there's something going on there and to not go for it, right? And of course, this goes along with where the money are assigned to. There are a lot of money assigned in that direction. There are actually not enough scientists for the money that are available. And once you figure that out, you can very well then, say, fine, this is done, and let's go back. But obviously, we are extremely far from that point. We are not even close to figure out what's happening with this biological part. Who else to do it? So therefore, is a drift more or less controlled, right, of the psychiatrist here, because it's like a gold mine, but not necessarily in the financial aspect, but in the scientific aspect. There are many other specialists who do the other work, the therapy, right? No one is doing this, so perhaps there is a certain drift. However, I would say psychiatry is too big to think about it as being just the biologists. There are a lot of people out there, and if you really do a literature search and look around, there are thousands of people who actually deal with the therapy like that. So why people get this sense about psychiatrists being that much biological is also mostly because they look in the newspaper and what's the fanciest thing that comes out and is the most popular is about a certain discovery at the biological level, and people read a lot about that, so you might think that, hey, this is what psychiatrists became, because the other thing has been around for more than 100 years or so, so it's not that, that much in the news and so forth. Okay?
I was just going to say that there tends to be trend in medicine towards the public taking what they want from the so-called happy pill is only just down the road. And the whole issue of how people grow in terms of things that we value historically in terms of character
Right.
is going to come into challenge.
That would be my last question that I take for today. I'm going to answer very simple to it. Prozac is one of the most likely pills to become the happy pill, let's say. And there are studies out there that show that people with depression who take Prozac actually become less depressed, right? But become more blunted. So their affect is on the blunted side. And they're actually able and equipped to face life. And they're not anymore limited biologically. However, if there is perhaps no meaning there or no engagement in the purposeful life, those people become blunt and there's nothing happening in their life. And they are ready to be happy, but not happy yet because there's nothing happening. All right? Thank you so much.